Depressive Disorders, Chapter 14. These are the terms that you need to be familiar with, and some of these you have already seen some of these terms, such as anergia, anhedonia, as some of these terms we have spoken about from day one of our class. So, some of the objectives that we will be working on is to talk about disruptive mood, dysregulation of disorder, persistent depressive disorder, also known as dysthymia, and menstrual disruptive dysphoria disorder. So, in depressive disorders, they all share the same symptoms of sadness, emptiness, irritability, somatic concerns, which we're talking about body concerns, body aches, symptoms, GI disturbances, headaches, migraines, over concerns about maybe chest pains. There can be all sorts of body aches or body concerns, okay? Also, impairment of thinking. That all of these impact a person's ability to function. So their success of completing daily livings, working at their job, taking care of themselves, their family, it impacts all of these, and they're not able to function at their highest level of their normal functioning. They're just not peaking and performing at their highest level. So major depressive disorders is one of the main disorders we talk about, but there's other things such as disruptive mood dysregulation, persistent depressive disorders, used to be called dysthymic disorders, premenstrual dysphoria, substance medication-induced depression, depressive disorder due to other medical conditions. So Jeff is a 19-year-old that's brought to the hospital after suicide attempts. His parents found him in the backyard wearing his favorite black jeans and a black t-shirt, but with one of his father's neckties. He had overdosed on some of his mother's pills, but his stomach was pumped in time, and he has just been admitted to your floor for a 24-hour suicide. So when we talk about his stomach being pumped, typically we're talking about that they used charcoal, and he had to drink it down himself, or they put a tube down and basically filtered it through the tube into his stomach. So it's usually charcoal that is put with, basically, and the best way I can describe it is with Carol syrup. Corn syrup kind of liquid, so it's liquefied, and it's charcoal, you guys. It's to help absorb out the medication so it doesn't get absorbed into the intestines, into the body, and it causes the person to puke, and whatever else is in the system, it will be absorbed in the charcoal and go out the other end. With this, some things you need to know: the patient does need to vomit before they leave the ER and arrive to your unit. Those are some of the things that you need to make sure have happened before you receive them from the ER. These are some important things that need to take place. So, persistent depressive disorder, formerly known as dysthymia, to just give you some description of it, they have low levels of depressed feelings most of the day, each day, okay? At least 2 years existing in an adult and at least 1 year in a child or adolescent. This has had to go on. And they need to have at least 2 or more of the following symptoms: a decrease in appetite or overeating, insomnia or hypersomnia, meaning sleeping too much, low energy, anergia, poor self-esteem, difficulty thinking, and hopelessness. Now, if you're looking at children that are anywhere from 6 to 18, you may see disruptive mood regulation, meaning they'll have verbal outbursts and anger. So instead of maybe seeing a depressed mood, you're going to see more of an irritability. their mood, they go from sad to very angry, irritable. So their mood seems to be more depressed and irritable. Temper tantrums can be seen. Outbursts, those type of things. But again, usually we see the onset of this in teen years, not as often as we see with children, but usually in teens, okay? Premenstrual dysphoric syndrome, if you haven't figured it out, it's usually clustered symptoms that last a week, the last week prior to the onset of the menstrual cycle. There's physical discomfort. You know, we get the bloating, ladies. We might be more sensitive to pain. There's mood shifts. We're more irritable. You might have cravings. There's emotional symptoms. You might cry more on top of being maybe more irritable, more sensitive. Men, ever notice this in any of the females in your life? Okay. Not all females get this. And so it varies, and symptomology varies. This is very much related to hormones. Okay. So again, it's the week prior to the onset of your menstrual cycle. So with this, there's usually anxiety along with this, feelings of feeling overwhelmed, and also difficulties concentrating. The symptoms decrease significantly or disappear once your period starts. Then we have substance-induced depression. This is when and this person doesn't have any other depressive symptoms when they're not using any alcohol or drugs. It only onsets when they're under the influence. And then there's other depression disorders associated with medical conditions, such as kidney failure, Parkinson's disease, Alzheimer's. We can see these symptoms with these diagnoses occurs, and also sometimes medications are not considered part of the treatment when they should be. They will help. And sometimes medications actually can cause these symptoms when you're trying to treat one of these disorders. So it can be a double-edged sword of trying to balance treating these disorders and not causing the symptoms, but these actual medical disorders can cause depression. So, major depression, this is the big one. You need to have 5 or more of the following symptoms in a 2-week period. Okay, so, and then plus on top of those 5 or more symptoms, you need to have at least one symptom of a depressed mood or a loss of interest and pleasure. Of course, our term, anhedonia. So, what are those 5? Weight loss and an appetite change, sleep disturbance, fatigue, change in physical activity, worthlessness or guilt or hopelessness, loss of ability to concentrate and make decision, recurrent or persistent thoughts of death. So, 5 or more of the following in a 2-week period, plus at least one of the symptoms of depressed mood or loss of interest or pleasure. So, it needs to persist for 2 weeks to 6 months. It's going to be chronic. It's going to be diagnosed as chronic if it lasts more than 2 years. You can have recurrent if you have episodes so it can recur and be episodic. Symptoms can cause distress or impaired function. Episodes not attributed to physiological effects, and its absence of manic or hypomanic episodes in order to be diagnosed with major depressive. depression. So if you get manic or hypomanic episodes, then that's where we look at what we call bipolar disorder, which we'll be talking about next week. So, leading cause of disability in the United States. So, major depression is a leading cause of disability in the United States for children and adolescents and older adults. And we always usually see comorbid diagnosis with major depression. It doesn't just stand alone. So, case study. During intake, Jeff doesn't speak much, but his parents are able to list the following symptoms they've observed in Jeff: weight loss and appetite change, insomnia, fatigue, worthlessness or guilt, loss of interest in his college classes, and even on his online games he usually plays with friends, and constant sadness. Jeff's parents have decided his lack of interest in things he used to enjoy, like games with his friends and his classmates, which he used to like. This may best be described by a term of what? What's the term? Ineptness, impedance, indolence, anhedonia. If you pick D, anhedonia, you're on target. So what about depression? Where is it all coming from? Well, we know that genetics is a huge factor. If it runs in the family, there's a good chance you can be linked. We also know that if you are a child of a parent and you're raised in an environment with a parent who is actively dealing with depression, there is a good chance as an adult you are going to have depressive issues. The environmental causes that play a factor. We know that biochemistry plays a factor, that if you have stressful life events, it's going to impact your serotonin and your norepinephrine, and it can cause you to lead to depression because it can change your permanent change of production of serotonin and norepinephrine if your stress levels stay high for too long. We know that alterations in your hormone regulations of your hypothalamic pituitary adrenal cortex axis, increased cortisols and corticotrophin levels causes depression. We know that if you have any inflammatory disease processes that affect your C-reactive proteins and your cytokines, and your interleukins, it's going to potentially cause depression. So we know that cancer causes depressions. We know that chemotherapy causes depression. We know these things. So we try to help our patients anticipate those elements. This is why we want our chemo patients, our cancer patients, to surround people and get their mindset in a very positive area and not surround themselves with negative thoughts, just for the mere fact that the mindset alone can bring on and help pull down that depressed set. We want them in a very positive area, focusing and meditating on positive thinking just to help them. And then we also know the gas response, okay? Genetics, biochemistry make up personality and destruction, or the diathesis stress model. Nature versus nurture, which I was talking about earlier. That environmental, nature and nurture being raised, the genetics and the chemistry. Okay. So, what do we treat with? What do we know? What do we know from our psychological factors? Cognitive therapy. A person's thoughts will result in emotions. Yes, they will. We know Beck's cognitive triad, that negative self, if you see yourself in a negative view, you're going to be seeing yourself negatively. If you're a pessimist and see the glass half empty all the time, that's how you're going to view your world, as half empty. If you believe negative reinforcement, then you will see your negative and your future in a negative light. So it's learning to teach yourself to see that glass half full. What is it full of? What can you see? What is the positive in this situation? That's how Beck talks about that cognitive triad. And you learn to teach yourself how to rethink, how to see your world, how to rethink the process to help you re-see things, and it helps then change your emotional response. And then we also talk about learned helplessness. When a person doesn't feel control over their situation, initially it increases their anxiousness, their anxiety, and then it's replaced by depression. So as I've talked about before, do you have depression first and then anxiety, or do you have anxiety and depression? Either way, one will follow the other. So the more you feel like you have control over your world, the more likely you are going to feel happier. But when you don't feel like you have control, when you don't feel like everything is going to turn out okay, then it won't. Your view of your world is going to be a view of negativity. So, assess behavior in a patient with depression. This is our next set of objectives. We're going to look at their affect, their thought processes, their feelings, their physical and behavior communication. We're going to formulate the 5 nursing diagnoses of a patient with depression, including the outcome criteria. So on top of those objectives, we are also going to work on naming some unrealistic expectations a nurse may have while working with a patient with depression and compare them to our own thoughts and role play 6 principles of communications. So the nursing assessment. So we have several rating scales, from the Beck Depression Rating Scale to the patient assessment tools, the Q9 to the PHQ9 to the PHQ16, just depending upon what tool you want to be using, to the Columbia Suicide Rating Scales. They're just a handful of different tools that are out there. We want to use those rating tools to make sure that we are assessing and having some measurable data to ensure our patient we're able to get some quality information at the beginning of treatment to the end of treatment, that we're able to get some baseline data and some end data to see if treatment is being effective or not. We're of course going to assess the beginning and end, and while through treatment, someone's suicide potential, their current thoughts with and without plan, their current actions, their risk factors, their protective factors. This is essential to do. It's our #1 highest element we need to do with somebody who does have depressive thoughts. We're going to work on key assessment findings such as anergia, psychomotor agitation or psychomotor retardation, somatic complaints, and vegetative signs. And when we say and talk about vegetative signs, we're talking about changes in bowel, eating, sleeping, and sex. That's what vegetative signs means. That's what we're looking about. And we're looking at comorbidity issues such as chronic pain. These are issues that patients are dealing with that could be that they're dealing with chronic issues, chronic illnesses that can contribute to the depression that they're dealing and leading to the depressive issues. Do realize that 15% of depressed people do succeed at committing suicide, and it is a risk factor. So areas that you want to be assessing, of course, affect, thought processes, mood, feelings, physical behaviors, communication, religious beliefs, and spirituality. Things to consider: age, children and adolescents and older adults. Why? What's the big thing with children and adolescents and older adults? they're actually going to be higher risk to commit suicide. They're also going to be a little bit more difficult to assess because of how symptomology is going to be. Again, children and adolescents are, especially the children, they're not going to typically look like a sad, depressed little kid. They may be coming out as angry. So you're going to be looking at an angry child versus a sad child possibly, or they're withdrawn and they're not talking. So you need to make sure that you're looking at getting the right information. They may be withdrawn. A teenager could be that irritable, okay, and not responding, not talking. They lose interest in school. You have to look at the big picture. They're social. Do they have friends? Are they retreating? Are they engaging in any any substance abuse? Are they having promiscuous sex? Are they preoccupied with death, with suicide? So you're needing to really take a look at not just what's going on at home, but outside of home when you're looking at children and adolescents. Now with older adults, there's going to be more likelihood of a lot more complaining about physical illness and emotional concerns. And you may completely overlook the fact that there is depression there because you get focused on the physical elements and not look at the emotional elements that are going on. On top of that, you may need to be using like a depression rating scale, like the Beck Depression Rating Scale, especially for that older adult. Just to make sure that you're picking up on the information. Remember, older adults are losing a lot of friends, are passing away, family may be passing away, and so they're starting to not have their support system. They may be starting to lose their support system. So you do want to make sure that you are connecting, okay? Make sure that you do your own self-assessment so that you are aware of your own prejudice, own thoughts, and own components with this. And make sure you feel what the patient is feeling. What does that mean? Feel what the patient is feeling. So again, do empathy. Make sure you recognize what that person is really saying and understand what they're saying. Use your empathy. So what question would be a priority when assessing for symptoms of major depression? Tell me about any special powers you believe you have. You look really sad. Have you ever thought of harming yourself? Your family says you never stop. How much sleep do you get? Do you ever find that you don't remember where you've been or what you've done? So if you answered B, you look really sad. Have you ever thought of harming yourself? You're on target. Again, we're in Western culture, so we're going to acknowledge the appearance of what they're looking like and try to attach it to a feeling. And we're going to be direct. And we're going to ask the direct question, have you ever thought of harming yourself? Because we need to assess for suicide. So now when we're looking at the nursing diagnosis, these are the things that we're going to be looking for. And this is actually in order of, well, it depends. The top two are our top priorities. Risk for suicide, because safety is always our highest priority. Now, the second one is hopelessness. Because if somebody is extremely hopeless, the risk for suicide is right behind the corner. Now, the others are going to be depending on severity. Ineffective coping, if somebody is not coping well, it's going to end up affecting self-care. It's going to affect risk for suicide. It's going to, of course, lead to hopelessness. Social isolation, spiritual distress, and self-care deficit. Self-care deficit could go up towards the top depending on how severe it is. So these are our top ones. Okay. So we're going to work on outcome identification. The primary outcome and what we work towards is recovery model. We're going to focus in on the patient's strengths. What are they good at? What are they strong at? And we're going to set up treatment goals that are going to be mutually developed. So patients got to have buy-in because they have a lot of homework to do. They've got to like what they're doing for their homework. They're going to need to like the coping skills that they're going to select and do, because if they don't like to do what the exercises are that they need to do to practice to help get themselves out of the depression, they're not going to do them. It's just like if you don't like to exercise and you have chosen for the patient that they're going to do 10-mile runs, and they hate to run, let alone sweat, and they live here in Florida, and you're going to have them outside running, there is no way that that patient is going to ever step foot outside and run. So you have to get goals set up that that everybody's going to buy in on, and base the plan and the goals with the patient's personal needs and values. So gear it towards the patient's phase of depression, their particular symptoms, can't talk today, and the patient's personal goals. So you're going to implement them, and you're going to implement things in phases, 3 phases. So realize with depression, and when somebody has major depression, they're going to be in treatment for basically 2 years, y'all. And that's no joke. It's going to take that long. The acute phase, when somebody is dealing with depression and they're needing to seek out, is going to take anywhere from 6 to 12 weeks for that acute part of it to start to really clear up. 6 to 12 weeks. And this is with getting on medications and starting some therapy. Because remember, our antidepressants is going to take 2 to 4 weeks just to start kicking in. And that's if we get the right med on board, the right time, the right amount, and then get it titrated up for it to really start kicking in. And then it's going to take 4 to 9 months to continue in therapy to get everything all stabilized. And that's if we don't have a whole lot of stressors going on at home, because what happens if part of the depression issue is also things going on like marital discord or domestic violence, or maybe there was a rape. Okay, so if we're just having depression that's associated with a chemical imbalance, that is just one piece of this whole puzzle. But then if we have other things in the environment that's added into this mess, that we have multiple things that we're dealing with. And even when I say that it's just the chemical, the brain imbalance, that still is a huge issue, because that in itself can be a very unpredictable component taking place with someone's brain and trying to get it back into a normal rhythm. And so then once it all stabilizes, you want to maintain it for 1 year or sometimes longer. So when your patient goes and says to you, I would like to stop my medications now, what do you think? One of the things you want to be able to say as a nurse is that you want to be able to let your brain stay stable for once it stabilizes for at least a year before you start to talk about weaning yourself off your medications. And that you want to talk with your doctor about it at that point. But you need to give your brain an opportunity to just stay stable and see that it stays stable. So we're going to be doing counseling and working on communication and effective communication. We're going to be doing a lot of health teaching and promotion about exercise, sleep, balanced diets, We're going to promote a lot of self-care activities. Those are just some of them that I was talking about. Then we're going to be working on yoga, meditation, deep breathing, journaling, just a variety of things. We're going to work on teamwork and safety and going to support groups. Everything to surround themselves with the best support that they can have. So now we're going to identify major classifications of those antidepressants, general advantages and disadvantages, and discuss the use of ECT for depressive disorders. So, choosing an antidepressant, symptoms and profiles of patients, side effects, sexual dysfunctions, weight gain, ease of administration, history of past responses, safety and medical SSRIs. I'm sorry, I forgot to mention this. Make sure you do your teaching again regarding driving. There may have headaches. There's going to be a fog with this in the beginning of the first couple weeks. It should clear. There may be a headache, and the more they concentrate, the worse the headache may be. Also with this, everybody needs to be warned that around the first, anywhere from 7 to 21 days into treatment, the patient may have increased suicide thoughts or have suicide thoughts where they didn't have them, and they need to report this because this is a black box warning. Especially in young adults and teenagers. We see this happen more frequently. Everybody needs to be warned about this and be able to talk about it and not hide it. A lot of people will hide it. So, with this all being said, MAOIs. Okay. Our last resort ones. This one affects the neurotransmitter, okay? And we have some issues because it is, Tramamine is a problem when you eat any Tramamine with this MAOI because it's going to cause a hypertensive crisis. The reason behind this is what will happen when you have Triamine and you're on an MAOI is it's going to cause vascular constriction. Okay, so it's going to take every blood vessel in your body and it's going to constrict it and squeeze it. Eyeballs, heart, muscle, anywhere there is a blood vessel, it's going to constrict. And it's going to then, of course, cause every blood pressure in your body to elevate until you pop like a balloon and you will pass away. And it can happen within 15 minutes of ingesting a Triamine food product. So when we talk about what food products we are discussing, this is on page 268. Okay, we are talking avocados, especially those that are overripe, fermented bean curds, soybeans, figs, bananas in large amounts, meats that are smoked and pickled, bolognas, pepperonis, salamis, dried or cured or smoked fish, pickled eggs, very aged cheese, certain beers that are imported, wines. Okay, so you've got to be very, very careful on different products that you're doing. Chocolate, fava beans, ginseng. So you have to just be very cautious about the types of food they have to restrict themselves on, and they have to be good. So you have to assess your patients to ensure which one is the right person to be eating this. This medication is also happens to be good for treating generalized anxiety disorders, obsessive compulsive disorders, PTSD, and bulimia. Besides the fact of having this severe adverse reaction, you also are going to have issues with orthostatic hypotension, weight gain, edema, cardiac rate and rhythm changes, constipation, urinary hesitancy, sexual dysfunctions, vertigo, overactivity, muscle twitching, hypomania, manic behaviors, insomnia, weakness, and fatigue. So, there's also some issues with drug-drug interactions, and there's some things you got to just memorize with this. You cannot take any kind of over-the-counter cold medications, that any kind of decongestant, allergy medicines. You just can't do it, you guys. And you got to memorize that with MAOIs, because you got to teach your patients, no, do not go get some over-the-counter meds. We used to, back in the day when I was a little kid, you couldn't even get a cold medication over the counter. They were all prescription because they just didn't exist. Now you can get all sorts of kind of things. You just can't do it. Tricyclics, cough syrups, any of that kind of stuff you can't do. Tricyclic antidepressants, narcotic, antihypertensives, sedatives, general anesthesia, stimulants, all those things, your patient's got to tell the doctor they're on this drug. They have to tell them. And then, of course, your foods that contain tramamine. Okay. So, if you have congestive heart failure, hypertension, cardiovascular disease, liver disease, or going to need surgery, and you're going and 10 days post-op, you cannot be on this med. You got to be taken off of it. And if you can't follow their diet restrictions, you cannot be on this medicine. Now, the good thing is they have made this medication now in patches. Not all the drugs are, but a good handful of the drugs are now. And because of this, it has helped decrease the severity of that vasoconstriction so that you can medically intervene and help your patient, where back a few years back, we weren't even able to do that. But still, it puts them at great risk. So these are just some of those restrictive things that we do have to teach the patient and have them understand the seriousness of it. So just reinforcing again, black box warning for suicide, especially in children and young adults on the SSRIs. Remember the serotonin syndrome. Too much serotonin occurs within several hours of taking a new drug. It can actually happen to a person without even mixing with other medications. That serotonin syndrome can occur. Again, restlessness, confusion, and rapid heart rate and high blood pressure. Those are going to be those first onset of that syndrome. Then followed with dilated pupils, loss of muscle control, twitching, muscle rigidity, heavy sweating, diarrhea, headache, shivering, and the goosebumps. Okay? And then the severity, when it gets severe and life-threatening, you're going to have high fever, seizures, irregular heartbeat, unconsciousness. And don't forget with triazidone, papyrism, and the prolonged painful erection. That's what I was talking about with the triazidone. So Jeff was just diagnosed with major depressive disorder. Which medication is healthcare provider most likely to start the patient on? SSRI, SNRI, tricyclic, mono, MAOI. Which one? If you said A, SSRI, you are on target. So plan a patient family education, discuss which side effects Jeff might experience on his new med regime. So what would you talk about? Would you talk about that it could cause some agitation and anxiety? Some sleep disturbances? Tremors, sexual dysfunction, like the inability to achieve orgasm, some decreased desire, libido, some tension headaches. maybe some dry mouth, some sweating, some weight changes, some mild nausea, some loose bowel movements. What should he do if he's experiencing these? Do you want him to talk to the doctor about it so that these things can address and that some of these will subside in a couple weeks? Other treatments for depression, ECT. We've gone over the ECT, but I do want you guys to read some of the information here in the book about it, just to make sure you've gone over that material. That's on page 264. Transmagnetic stimulation, that is also on page 264. Vagal nerve stimulation. Again, that's like having a pacemaker into your vagal nerve into your neck. Deep brain stimulation, pacemaker concept to your deep brain. Again, it's going to help stimulate the brain, increasing serotonin into the brain. We have light therapy. Usually we see this in SADS, seasonal affective disorder. Usually this is used in people who are up in the northern part of the country and in Alaska when they go months and months without any light. And they are in need of having some light, and they basically get under light and get the UV rays so that they are able to affect their melatonin and increase their melatonin levels so that they are less depressed. Okay. Then there's stuff like serotonin St. John's wort that help affect serotonin. It comes from a flower, and it's a natural herb type product that is utilized to help to address serotonin in another angle. Again, it's not completely regulated, so you don't know how much you're actually always getting in each of the capsules that are being served or delivered in the products that are out there. So you have to be careful and mindful when taking this. And of course, should always be reported to your doctor. Then, of course, we know that exercise increases endorphins, which increases serotonin, and that, of course, elevates mood and happiness. Okay. So these are just some of the things that are alternative treatments that are out there and available to help treat a patient. These are just some slides just to help reinforce on ECT. We also know that ECT can be used for psychotic illnesses, and we know that depression, occasionally we will see psychosis with it. And I will let you just look through those. I won't go over that. And these are just details on some of these other treatments. Advanced practice interventions, again, psychotherapy, cognitive behavioral, interpersonal. And remember, interpersonal is time limited, focused, and behavioral therapy. Okay. And then, of course, therapy. So, nursing process, the evaluation. Again, always suicide ideation. We have to evaluate. We have to continue intake, sleep pattern, personal hygiene and grooming, self-esteem, social interaction. These are all the things that we need to continue to evaluate with our patient. And when I talked about earlier with intake with a drop of appetite, sometimes it's an increase of appetite also. Someone can overeat versus undereat. So quality improvement in 2020, the national goals is to see an increase in the percentage of people living with major depression who receive treatment. So we want to see people who have major depression get treatment, at least 75% of them getting treatment. We want to see the increase in number of physicians' office who routinely screening our patients for depression. And of course, we want to see links to reliable outcome measures. We want to see the results. We want to see if the results are accurate, if there's improvement or not in appropriate treatments that are out there. So a patient with major depression walks and moves slowly. Which term should the nurse use to document the findings? Psychomotor retardation, psychomotor agitation, vegetative signs, anhedonia. You should have picked A, psychomotor retardation. Which assessment finding in a patient's major depressive represents a vegetative sign? Restlessness, hypersomnia, feelings of guilt, frequent crying. B, hypersomnia.